Iris has also joined us. Iris Dotan. She is the Director Division of Gastroenterology at the Rabin Medical Center in Israel. A good friend that comes to me first, of course, when I speak. But she is an IBD stalwart, a global IBD stalwart, a key member and of the International Organization of Inflammatory Bowel Disease. And she will tell us about the way forward with diet in IBD and dietary therapy and how things might change in the future. Iris, over to you, please.
Thank you very much, Rupa. Thank you for this very kind introduction. I hope that you'll let me share my screen in a second. I'd like to, while I'm trying to, am I allowed to share my screen? Yeah, this is great. And here is the presentation. And just let me know if you can see my slide.
Yes, we can, Iris.
Okay. So thank you very much, Dr. Banerjee, Dr. Tandon, and of course the audience for this opportunity to be part of this AIG Focus on Nutrition session. Actually, it's been a great pleasure for me to collaborate with the AIG as well as to the team at the Rabin Medical Center, which is the flagship hospital of Clalit Health Services in Israel. And actually, Clalit Health Services takes care of half of the Israeli population. So imagine what would that be in Indian magnitude. But I think that this is very interesting that we can collaborate with you, and we have so many common things with our Indian colleagues. It's really a great pleasure for me to be here. These are my disclosures. And when I'm talking to audiences with the Emerging Nation Consortium, which I had the pleasure of participating in, and really I would like to congratulate again AIG leadership and specifically Europa and the members of the Emerging Nation Consortium for being so aware of the rising incidence of IBD. That was associated, you know, the title of this, because it's been taken from quite a recent review that you all know from Gil Kaplan and Suen, of course, who's also a collaborator and advisor to the Emerging Nation Consortium. So we see this rising incidence in IBD, and we attribute a lot of it to industrialization and to modern lifestyle. It used to be called Western lifestyle, but of course, as you know, and as everyone who goes to India or to one of the other emerging nations, you can see that it's not only about Western lifestyle anymore, but it's about modern lifestyle in any place in the world. And I think that your awareness is very important, and hopefully you will be able to prevent this pandemic, right? Until COVID-19, we were saying that IBD is the immunologic pandemic of the world, and hopefully you will be able to prevent it because you address nutrition, which I think is a very important cause of the rise in inflammatory bowel diseases. And you already discussed this, so we will not go into many details into the pathogenesis of the interaction between diet and the microbiome, and how, if you can see my mouse, and how the healthy microbiome is turning into a dysbiotic microbiome as the one that we see in inflammatory bowel diseases. And some aspects that were already mentioned, but I will mention some of them because they are important when we're talking about how can diet move forward. So diverse microbiota turns into reduced diversity. We know that this is a hallmark of the dysbiotic IBD microbiome. The mucus layer is actually not researched enough, but the mucus layer is changing not only by its size, but also by its function, thereby allowing bacteria, not only because of the closer interaction of bacteria and the epithelial layer, but also because of the function of the mucus, which is a point of interest of my lab, by the way. And we're trying to see how the function, the changing function of the mucus is actually affecting the interaction of different kinds of microbiota with the epithelium. And of course, last but not least, the intestinal mucosa. with one layer, imagine that, one layer of epithelial cells that differentiate this outer world with its microbiome and nutritional parts, the many enzymes, of course, and secretions of the intestinal tract, from the very active mucosal immune system that changes enormously when we move from the healthy homeostasis to the very disrupted immune consequences of this dysbiosis interaction with the mucosal immune system. So this was trying to highlight the mucosal immune system that was already touched upon. And these are the areas where diet can influence and how diet can affect this inflammation. So you mentioned it already in part, and of course Aryeh Levin, or also from Israel, reviewed this extensively with Rotem Sigal-Boneh, who is one of our prominent dietitians in Israel, and actually looking into how the diet can affect specifically the mucosal immune system, and indirectly by affecting the microbiome and many aspects of multiple dietary components, whereby each one of them can affect, again, as I said, directly or indirectly the mucosal immune system and the microbiome. And then the microbiome can affect directly or indirectly the mucosal immune system, and so on and so forth. So diet undoubtedly is a very meaningful trigger, and as we will discuss, perhaps also a therapy in inflammatory bowel diseases. So we all know for many years how diet can affect inflammatory bowel diseases, and we will of course focus on Crohn's disease, but maybe in the end mention also ulcerative colitis. And we know for years that exclusive enteral nutrition is a therapy for patients with active Crohn's disease. We knew it first in the pediatric population, but also we know it recently also for the adult patients with Crohn's disease, with active Crohn's disease. And actually Tamar Pfeffer-Geek from our division had looked at it specifically in adults and also for adults with strictures, as was so nicely alluded before. So exclusive enteral nutrition can be provided. Usually it is given for either 4 to 8 weeks in patients. This is the duration that patients can usually tolerate it. And of course, it needs to be done together with the dietitians and together with the patients who need exclusive enteral nutrition. Usually its effects are prominent. However, as we would all know, this is hard to tolerate in the pediatric population, where you usually would need to use a nasogastric kind of the nasogastric tube, or in the more adult patients who need to drink these drinks. However, its effects are very prominent. But recently, and you asked me to talk about the way forward. So actually recently we are going, when we're talking about dietary therapy of inflammatory bowel diseases and specifically of Crohn's disease, we're trying to move from the formulas that were given for years for patients with IBD to whole food-based dietary therapies. And one important reason is the intolerance to eating only formulas because of their taste, because people want to eat. Eating is a part of life, and it's a good part of life, and it was very nicely shown before that we don't want to exclude food. We actually want to provide more food, and we want to provide more diversity. So actually recently, very recently, actually in 2019, 2 very important studies were published showing how diet can treat Crohn's disease. First, again, from Israel, from Aryeh Levin's group, the Crohn's disease exclusion diet. And this is how Aryeh was trying to show its importance by comparing Crohn's disease exclusion diet and partial enteral nutrition against exclusive enteral nutrition. And in this landmark, actually, I think, study, he was showing that Crohn's disease exclusion diet, the CDED, with partial enteral nutrition, where actually processed foods, alcohol, coffee, gluten, saturated fat, red meat, and dairy products were excluded, and a specific menu, a restricted menu though, but still a specific menu, was provided according to a specific therapy, according to a specific schedule, where in certain weeks more and more components are being provided back. And he was able to show the primary endpoint, cleverly enough here, was tolerance. And this diet, of course, was more tolerated than exclusive enteral nutrition, so it was superior to that. But actually, in the maintenance part, it was also associated with reduction of certain dysbiotic microbiota such as proteobacteria and improved intestinal permeability, so showing also some mechanistic aspect, not only the clinical aspects. And in the same time, from the UK, the CD treat, Crohn's disease treatment with eating diet was shown in the pediatric population, actually shown for the first time on 5 participants only. But in this study, what was specific was that there was also a mechanistic arm trying to show the effects on the metabolome, on the microbiome, in murine models. And again here, they were able to show that this Crohn's disease with eating diet that again excluded high fiber foods, alcohol, gluten, lactose. You can see that there are many common parts to these diets. And it was, of course, more palatable than what we used to think about exclusive enteral nutrition, but it also was associated with improvement of inflammation, for instance, decreased fecal calprotectin and decreased inflammation and an increase in some of the outcomes that we want for our patients, for instance, alteration of diversity and improvement in intestinal inflammation. This is why later on the IOIBD, the International Organization for the Study of IBD, tried to provide some dietary guidance to control and prevent relapse in inflammatory bowel diseases. Now, since we all want to be very evidence-based, so of course the recommendations here are very careful and are phrased in a very diplomatic way, but already we can suggest to our patients that there are some things that are more prudent to use in Crohn's disease and also in ulcerative colitis, and for some aspects it's more prudent to avoid. For instance, in Crohn's disease, and we said that we will focus mainly on Crohn's disease, it's more prudent to add vegetables and fruits, and it's more prudent to avoid saturated and trans fat, emulsifiers, carrageenans, artificial sweeteners, maltodextrins, and titanium, which is coming more and more into the focus. In ulcerative colitis, it is more prudent to add omega-3 oils from fish and food specifically. And then to avoid red meat, processed meats, which have been accused repeatedly to be associated with ulcerative colitis, dairy fat, saturated and trans fats, and again, the others are quite similar with Crohn's disease. So again, we can be more specific in our recommendations to patients with inflammatory bowel diseases. But the important questions that come into mind are how these diets can affect and what is their effect. So a question that was recently asked on a population-based, and 2 studies again coming in 2020. On your left, you would see the European approach, and on your right, you would see a study from the United States, huge population-based studies asking, can healthy diet prevent IBD? So the answer from Europe, from Sweden specifically, was that yes. Adherence to Mediterranean diet, so they were specific about components of the Mediterranean diet, was associated, interestingly, with a lower risk of later onset Crohn's disease. So they looked at many patients, actually thousands and thousands of patients from the Swedish cohorts, and they were able to show that if they looked, and this was based on food frequency questionnaire components and on outcomes, and they were able to show that later onset Crohn's disease was prevented in populations, was lower in populations that were eating Mediterranean diet. And on a similar concept, but with a different diet, so from Anantakrishnan group, looking again at huge population-based, mainly population-based from the United States cohorts, and they were showing that dietary inflammatory potential was lower in patients that were having an empiric dietary inflammatory pattern that was lower, and in these patients, Crohn's disease, again, specifically, was prevented. Now, this is actually trying, and I'll show you a focus on how we can differentiate between these various, when we say a healthy diet, what do we mean? So I mentioned already the Crohn's disease exclusion diet and the CD treat. We mentioned the Mediterranean diet. There is the specific carbohydrate. You mentioned the low FODMAP diet. So there are multiple diets that are considered healthy. And is there a common denominator? So you see that several of these diets have components that need to be, that are not allowed. Okay, you can see them here, for instance, in the brown rectangles, and some of them are actually mandatory or allowed, and you can see them here in the lighter blue or the dark blue. For instance, specific fruits that are mandatory or allowed in these diets. And many of them are included, as you see, in the Mediterranean diet. So what we actually eat here in the Mediterranean area is commonly recommended by many of these diets. And as you see, the Mediterranean diet pyramid, and I'm sure all of you are familiar with it, excuse me, is actually requesting to avoid as much as possible meat and sweets, and to have the majority of the diet being based on fruits, vegetables, to drink a lot of water, to use in moderation, but to use red wine, and to avoid poultry, eggs, and cheese as much as possible, to eat them in moderation. Okay, and of course, to base your proteins on fish mainly. And when you look, again, if we want to focus on this diet, wait, I'll move this a little bit to the side, so we can see that it is not only based on specific components that are recommended by many healthy diets, but also that it can affect positively some of the bacteria that we want to have more in our patients, and it can affect the bacteria that we want to have less in our patients, therefore potentially decreasing dysbiosis, therefore potentially having a better anti-inflammatory outcome in our patients. And we wanted to take advantage of this several years ago when we were studying diet and the microbiome. And we, as you know, focus on patients after pouch surgery, which we think are a man-made model of inflammatory bowel disease, whereas patients with ulcerative colitis that have their large bowel resected and an ileal pouch is made out of normal small bowel, are developing a disease, pouchitis, that resembles Crohn's disease. And we look at these patients, we focus on them very intensively, thinking that they're a model of IBD. And you see here many of the studies that came from our group. Many of them are done by dietitians, and specifically by Lihi Godni, who is attending these sessions and prepared many of these slides. And our approach to these patients would be that diet would be one of the issues that we are testing, and looking at each patient online. Meaning online is that when a patient is coming, we're asking him or her on his or her dietary habits, and we're trying to modify the diet so that inflammation is decreased based on that. And I want to share some of the that we have from this interesting patient population. We noticed that Mediterranean diet in these patients was associated with beneficial outcomes after pouch surgery. Mediterranean diet was associated with lower levels of inflammatory markers in these patients, specifically CRP and fecal calprotectin, and moreover that fruit consumption was associated with a lower rate of having pouchitis. So here you see the patients that actually sustained a normal pouch, and these patients actually consumed more fruits and were able to sustain a lower level of pouchitis. Diet was associated in these patients with microbial diversity and composition. And you can see here that these were the patients that consumed vegetables, but more so fruits. And we could also specify which fruits would lead to which different bacteria. And you can see here the bacteria that were noticed in these patients according to the different fruits that they consumed. So we think that maybe you can combine the fruits with the bacteria that you want to modify in a specific patient. And this is coming from another very successful graduate student from our lab, together with Uri Gofna from the Tel Aviv University, that was able to show that dietary fiber consumption was associated with butyrate production. And he was able to show it in patients that were controlled ulcerative colitis, Crohn's disease, those with a normal pouch and those with pouchitis. And you can see that butyrate producing enzymes were positively correlated with dietary fiber consumption. And again, specifically from fruits and vegetables. So I think this is a very important insight from our study. And Lee Godney is now summarizing 2 different diets that we were trying to look at in patients after pouch surgery. One of them was the Mediterranean diet. One of them was a specific carbohydrate diet. And she cooked and provided those diets to our patients after pouch surgery, and was able to show that rapidly and personally they affected inflammation in multiple mechanisms. And I'm showing you here only part of them, but they were affecting clinical parameters, quality of life, metabolic outcomes, microbial composition, of course, and even we are looking at the epithelial barrier function in these patients. And what she's doing now, she's trying to show us how these interactions, these multi-omic interactions are changing in patients, whether you are giving them the Mediterranean diet or the specific carbohydrate diet. And what we're suggesting is that one side does not fit all, and you should fit the diet like you fit the medication, like you try to combine infliximab to a patient with IBD, maybe you will fit Mediterranean diet. So this is what we think about road ahead, and now we are combining an IBD Mediterranean nutritional education program so that when we tailor the diet to a specific patient, we can personalize how he or she are using this diet. And actually we tried it, I'll finish by that, we tried it first on ourselves. So you see here, this symbolizes many participants, not patients, hopefully, from our group. And we did this IBD-Med intervention on us, and we used this educational program, and that improved the adherence to Mediterranean diet in healthy controls. These were us, members of the multidisciplinary team. After 1 month, so this was the daily med score. We were adherent more to the diet that was suggested. And after 6 months, we were quite good in it. You see that we didn't go back to our bad habits, but yes, it needs to be like maintenance therapy. It needs to be educated and re-educated. And talking about the collaboration with the AIG and with our Indian colleagues, we found many common denominators between Israeli or Mediterranean food and the Indian food. And I'm sure that many of you can recognize here Indian foods. And here you can see the Mediterranean counterparts. And now we are trying to see how Mediterranean the concepts of the Mediterranean diet, and this was prepared by Sarin Eliel Fatal, another fantastic dietitian from our group. And you can see here your foods. I hope you can recognize them. And here you can see our foods from the Mediterranean basin. And now we are going to share them with our Indian colleagues, hoping that we might modify disease in India and in Israel when we're treating patients with Mediterranean concepts of the diet. And here you can see our collaboration, and I'm sure you can recognize some of your colleagues and some of our colleagues in these discussions that we are already ongoing, and hopefully we will be able to have more and more interaction. So when we're talking about the way forward, I hope that I was able to reiterate how diet and the gut microbiome play a role in IBD pathophysiology, and the diet and microbial composition and function can be changed rapidly after dietary interventions. And we think that microbial targeted dietary therapy interventions are the way forward, and we need to stratify patients so that these diets can be given specifically to them. And diet, of course, I don't need to say to this audience, is an integral part of the multidisciplinary care of patients with IBD. And with this, I'd like to finish and thank you for your attention. This is our center in a very sunny day like today. Hopefully, we'll be able to see all of you here soon. Thank you very much.